So the next topic, we're going to have a tandem speakers, Dr. Benchimol and Dr. Huth, and we're going to talk about vaccinations. And there's two really important reasons we want to really talk about this. One is with the medications we use, there's a lot more risk of developing some of these preventable illnesses. And there's now a lot of talk that some of these preventable illnesses may be triggering off, otherwise stable IBD. This winter, we had a very, very difficult time. The virus that came through Ottawa put a number of our kids in hospital. It was one of the worst winters ever. So we're going to be really working on these preventable illnesses this coming year.
So we're going to be speaking about vaccinations and IBD and what to look out for, what to know about them for kids and also for the families as well. And the reason we're speaking about this is because the Centers for Disease Control in the U.S. really declared vaccines the #1 great public health achievement of the 20th century. And it ranked ahead of motor vehicle safety, safer workplaces, and control of infectious diseases in general as the biggest advance in medicine and public health in preventing illness of the 20th century. And the reason for that is these numbers here. You can see that on average in the 20th century, the number of people who were stricken with these illnesses were in the hundreds of thousands. And by 2010, the morbidity had dropped significantly. Many of these illnesses, these infectious diseases, have been completely eradicated in North America. Some have not, mostly because the vaccines aren't perfect, that they do not prevent 100% of illness, but most of them have done quite well. I just bring your attention to the measles number there, the number 61 in 2010, and just bear that number in mind and what we're going to talk about in a second, okay? What's true, though, is that vaccines, like every other thing that you put in your body, like every other medication, vaccines are not without risk. No vaccine is 100% safe. There are rare side effects and common side effects as well. No vaccine is 100% effective. So you're not 100% protected when you get the vaccine. You're just trying to balance the risk and the benefit. All vaccines have potential side effects, mostly mild and rarely severe, and the risk of the disease far outweighs the risk of the vaccine in general. So that's the reason that we give the vaccine. The vaccine wouldn't be on the market if the risk of the vaccine was so high that it outweighed the disease. That's important to remember when you think about the flu vaccine. I don't have the numbers. This study was just published last week out of ISIS, the Institute for Clinical Evaluative Sciences. But the flu vaccine has a risk of a rare neurologic condition called Guillain-Barré syndrome. And this study that was published by Jeff Kwong in Toronto found that, in fact, everybody was worried about this vaccine causing it. In fact, the flu also causes it, and the risk of you getting that GBS, or Guillain-Barré syndrome, is higher after getting the flu than it is after getting the vaccine. So again, the risks of not getting the vaccine outweigh the risk of the vaccine itself. So the false assumption is that avoiding the vaccine would be safer. And by choosing not to vaccinate, you take on the risk of the disease itself. Both vaccinating and not vaccinating carry risks. And bringing it back to measles, a child who's not immunized against measles is about 35 times more likely to contract the disease in North America than a child who is immunized. That's important in Britain right now because in the last year in Britain, you remember 61 cases in North America in 2010. There have been over 2,000 cases of measles in Britain. The reason for that, many of you may be aware that in the year 2000, there was publications that insinuated that the measles vaccine caused autism in children. They came out of Britain. And British people started not vaccinating their children at about a year old when we get the MMR vaccine. And so now, 10, 15, 20 years later, we're dealing with the consequences of all these children who were not immunized over the last 10 years, spreading measles around and getting measles. And now we've got almost 20 deaths in Great Britain as a result of the not being immunized. So it's important to remember that it's not without risk to choose not to immunize patients. So let's talk about specifically all of your cases. So IBD, inflammatory bowel disease. So what do we worry about in terms of vaccines and vaccination in children with IBD? The first question we always ask is an IBD patient more likely to get an infectious disease than somebody walking around a general population? So more likely to get a disease would be considered immunocompromised. Their immune system isn't functioning properly. So there are a number of medical criteria that a patient would need to be categorized in to be considered immunocompromised. The first is that there's a defective mucosal immunity. So your mucosal system, so your gums, your intestines, block infections, infectious diseases, and bacteria from crossing over into the bloodstream. It acts as a barrier. So clearly we know that in patients with IBD, there is a defective mucosal immunity. There's a defective immune system. And perhaps Dr. Mack will speak a little bit more about this later. But we know that bacteria aren't quite normal in the gut in people with IBD, and there's more crossover, more permeability of the gut mucosa. So IBD patients in general do qualify for that category. Is there a systemic immune defect? So if I measured your immune system, would a person with IBD be considered immunodeficient? And generally, no. I mean, people's immune systems, the cells that fight infections in their blood are completely normal whether you have IBD or not. And then do you have any risk factors for what we call opportunistic infection? So an opportunistic infection is an infection that everybody else would be able to fight off, but if you have an immunodeficiency, you're not able to. And there are some inherent risk factors for opportunistic infections: older age, so elderly people, comorbidities, so having other diseases at the same time, and then malnutrition. And clearly, malnutrition is a big deal in patients with IBD. When they're sick, they can be very malnourished. So that's the one risk factor of all those three that IBD patients might have. And then there's acquired risk factors for opportunistic infections, something that you get later on, not part of your own body. And those risk factors are using immunocompromising medications, immunomodulators like azathioprine or methotrexate, as well as biologics like infliximab and adalimumab. And clearly, IBD patients, we use those medications on IBD patients. And then being exposed to these bugs, which isn't generally a major issue in Canada, and geographic clustering, meaning you're passing it from one person to another within a very small geographic space. Again, not a major issue in Canada. So there are some characteristics, but in general, IBD patients are immunocompromised mostly because of the treatments we use for them, not because they're inherently unwell, although there may be exceptions, such as if they're really malnourished. So the recommendations for immunocompromised people in general are that all the usual vaccines be given, all the usual strategies be used, except that we don't use live vaccines. And we'll talk a little bit more about that in a second. So it's important that in terms of the usual vaccines, we don't forget about the common boosters that we give to everyone, which are often forgotten about because teenagers don't tend to go see the doctor on a regular basis, or they don't bother. So the ones that we usually give in the teenage years in terms of boosters are the tetanus, diphtheria, and pertussis boosters, as well as yearly influenza immunization. Those are all the ones that are recommended in Canada for sort of the teenage years. So it's important, knowing that you might be on, or your child might be on, medications that lower their immune system, that they're at least protected against the stuff that we can protect them against, meaning the standard vaccines. The European Crohn's and Colitis Organization has defined what an immunocompromised IBD patient means, and it's really about their medications. So they define anybody who's on azathioprine, 6-MP, methotrexate, infliximab, or adalimumab as immunocompromised. Additionally, if your child is on prednisone at a dose of 2 milligrams per kilogram per day, which is a much higher, about double the dose that we tend to use, or is on more than 20 milligrams per day of prednisone, then the child is considered immunocompromised. As well, if there's no spleen for whatever reason, sickle cell disease, or that there's been surgery or a trauma, then they're considered immunocompromised as well. So let's talk about immunocompromised patients and the recommendations given for IBD patients who don't have a functioning or a properly functioning immune system. So first of all, it's important to avoid live virus vaccines. So most vaccines are not live virus. We'll talk about the ones that are, but avoid the ones that are. And that means that you have to give a live virus vaccine 3 weeks before starting any of these therapies, these immunocompromising therapies, and preferably right at the diagnosis with IBD so that you don't have to worry about it later on in case you need to use these medications. And then we want to discontinue immunosuppression, the medicines, 3 or more months and then give the vaccine after that, the live virus vaccine. Otherwise, you risk the live virus vaccine causing the disease that you're immunizing against. So examples of live attenuated vaccines, so MMR, measles, mumps, and rubella vaccine, which is really only given at 12 months and 18 months, so not a big concern with most of our kids being diagnosed sort of 5 years and up. Chickenpox vaccine is a big concern because not everybody has had it and not everybody is immune to chickenpox. So we always check whether a patient is immune to chickenpox right at the time of diagnosis. If they're not and we're able to immunize them before starting one of these immunosuppressing medications, we do. Otherwise, we will warn you that if you're exposed to chickenpox or if you develop the signs of chickenpox, that you need special antiviral medication, immunoglobulin, to prevent the chickenpox from causing serious harm. Rotavirus is given to newborns, again, not a major issue in our patients. Yellow fever is a travel vaccine, so it's important that if your family is going to anywhere where travel vaccines are needed, that you speak to a doctor about what medications your child is on. And then oral poliovirus we don't have in Canada. Smallpox is not given routinely. And the live attenuated influenza vaccine, which is the nasal spray flu vaccine, should not be given in anybody who's immunocompromised. So IBD patients who are on the medications should be getting the flu shot and not the nasal spray vaccine. So again, we make sure that we try to, anyway, do the live virus vaccines before the immunosuppressing medications are started. And the non-live virus vaccines, though, are allowed if you're immunosuppressed. However, we try to give it at a time where there's minimal medications on board. So we may not give it when you're on prednisone plus another medication. We might wait for the prednisone to be done. So the non-live virus vaccines that are important to remember are hepatitis A, which is not routine in Canada, but if you travel to Mexico, your child should be getting it. Hepatitis B as well, which is routine in grade 7. And then HPV, and we'll talk a little bit about HPV in a second. The pneumococcal 23-valent vaccine, Pneumovax, is only given for immunocompromised patients, and it protects against invasive pneumococcal disease, so pneumonia or meningitis. It's not a perfect vaccine, but it does protect. About 74% effective against the invasive pneumococcal vaccine in adults in one study, 28% effective against pneumonia, mostly because most pneumonias are from multiple bugs or from viruses. Oops, didn't mean to turn that off, sorry. And then meningococcus vaccine protects against meningococcemia, which is another bacterial sepsis, and meningitis. The serogroup C is almost completely gone now in Canada because we vaccinate newborns against serogroup C, but now that's been taken over by serogroup B, so this vaccine protects against that serogroup B. So what about HPV vaccine? This is the herpes papillomavirus. We know that women with IBD are at increased risk for cervical dysplasia and therefore cervical cancer, likely as a result of the immunosuppression. Azathioprine is what these studies were done in. Resulting in increased infection rates and ability for the virus to transform the cervix and cause cervical cancer. So HPV vaccine in Ontario is recommended for all women and girls aged 9 to 26. It's now given usually in schools when they're around 12 or 13, and that's Gardasil mostly in schools now. However, we also know that HPV not only causes cervical dysplasia, but causes about 25% of all oral cancers and 35% of all head and neck cancers. So that includes men and boys. So the recommendations, the new recommendations from this past year by the Public Health Agency of Canada is that all boys get the HPV vaccine as well between age 9 and 26. Now, unfortunately, the Ontario government is not paying for it and it's not being given in schools yet. It hopefully will soon. So it does mean going to your family doctor and paying for the vaccine, but considering the risk in women, I think it's very well worth it to immunize boys against HPV as well.